Welcome to the Long COVID and Post-Infectious Syndromes Echo, a collaborative effort between the University of Utah and Bateman Horne Center. I'm Clayton Powers, Doctor of Physical Therapy at the University of Utah and also Director of Education at Bateman Horne Center. I'm joined by Sarah Day, Project Echo Lead at University of Utah. And today's session is being recorded, but all participant details or sensitive information will be removed before it's shared on the website or social media. After the session, Sarah will email CME instructions and a copy of the slide deck. And please note that the CME credit must be claimed by midnight tonight. It may take up to 24 hours to appear on your CME profile. And we invite you to introduce yourself in the chat and use the chat to ask questions or make comments throughout the presentation. We also want to remind everyone that this is a clinician-only forum, so we try to stay professionally focused. Today, we're privileged to have Katie Woolf, Doctor of Physical Therapy and Pelvic Floor Therapist. And Dr. Woolf works as a quality consultant at University of Utah and is here to talk to us about sexual health and chronic illness. Thank you, Katie, for being willing to talk to us today.
Thank you for being willing to listen to this subject. I think it's very important to talk about sexual health and kind of chronic illness and where things overlap and exploring that intersection of health and ongoing recovery because sexual activity is an activity of daily living. And we want to make sure that people feel comfortable discussing this with their primary care or their rehab professionals. So I will go ahead and get started. With that being said, I don't have anything to disclose and no conflict of interest. The table of contents that I wanted to go over today include a quick overview of pelvic floor and pelvic floor PT, the physiological and psychological effects of arousal, sexual health and chronic illness, and then skin and mucosal health related to this area, but then also some clinical screening tools and how do we integrate these strategies into our clinical practice. With that being said, let's review a little bit of pelvic floor and pelvic floor anatomy and functions. So I know we've dove into this and we've talked about some pelvic floor related to chronic illness over time, but I just wanted to review. There are multiple layers to these tissues. So layer 1, layer 2 are more closing. They act as more sphincteric functions. And then layer 3 is a little bit more lifting or levator ani, which is made up of multiple muscle groups. Pelvic floor primarily acts against gravity. It is triangular shape for the urogenital triangle and triangular shape for the rectal triangle. We have unique fiber directions with fascia also attaching to this and muscles attaching to muscles. It's a very confined space and we have a lot of things that travel through this pelvic ring with our bowel, bladder, and potentially even a vaginal canal in this area. It's very closely related to the sciatic nerve, but also the lumbar pelvic plexus. The pelvic floor has two primary nerves that innervate the area, the pudendal nerve and the levator ani nerve. And with the pudendal nerve being a primary driver for sensory and motor. And so when we think about sexual relations and the ability to sense and feel, these are the most distal nerves, and we want to make sure that all nerves are functioning appropriately. Taking us on to also the function of the pelvic floor, it is supportive of those internal organs. It is sphincteric or sealing. It helps with our sewage system, evacuating and holding things in. But it's also designed to help with our sexual function. It's there for stability of our pelvis and our hips. And it also is our sup pump. It helps with the vascular and lymphatic flow. These muscles have a primary action of remaining closed and supporting the body during mobility and holding in those organs, but also a secondary reaction to anytime we load the tissues, we cough, anytime those muscles need to react. With any muscle in the body, we need to appreciate that sarcopenia can start as early as our 40s, and it can then increase throughout our 60s and through our 80s. And so anytime we talk about muscle development or muscle strength, pelvic floor should also be included in that area. These are mostly under autonomic control. We just expect them to work. It doesn't have an antagonist like the biceps or the triceps have. And so when we think about these tissues, we need to make sure that all systems are working appropriately. Which takes me to why pelvic floor PT is so important. When we look at these areas, we are orthopedic therapists first, but we also have a strength in kind of looking at these different systems. We care about the musculoskeletal system. We care about the bowels. We care about sexual health, lymphatic, bladder, and autonomic symptoms. We care about the orthostatic intolerance. We care about the tachycardic syndromes because we know blood cannot circulate in all areas. We also know that these areas help us with so many of our functions. And if our pelvic floor isn't working appropriately, it can also contribute to the story of our patients who experience chronic illness, specifically post-COVID and CAST chronic fatigue. And we know that that is something that can be really impactful in patients' lives if any one of these areas is not working appropriately. Today's focus will really be on that sexual health, but I wanted to kind of break it down. What does sexual health kind of look like? It's not just about achieving intercourse or orgasm or stimulation. It's also about kind of emotional connections and the bonding that sexuality can bring for us. When we look at these different areas, I care about what's happening with the internal tissues via endometriosis, the skin, the arousal, family planning, or even prolapse. Each one of these can be impacted because of COVID or because of other illnesses or viral syndromes, and we want to make sure that we're addressing those for patients. Bowels can cause straining, cramping, swelling. We can see dysfunction that can make us be impacted in this area. We can see bladder emptying and dysfunction in the bladder, encroaching on the vaginal canal and or function of the penile tissues. And so we want to think about this as a holistic person and not just parts. So why is that important? What's happening during the phases of arousal, physically and psychologically? And that brings me to my next section that I really wanted to dive into. So from a physiological mechanism, what's happening during arousal? The role of the pelvic floor enhances blood flow and supports the arousal and the organs. It gives a base for the phallus to be stabilized, or gives a stability to the clitoral erection. We also can see that there's a lot of swelling that happens in this area. We see elongation of the phallus. We see blood flow coming to the tissues, but that also triggers an autonomic nervous response changes where we see elevated heart rate, potentially respiratory rate increasing, and that heightens sexual sensitivity. When we think about the changes to the cardiovascular system that we will see in our patients and the respiratory changes, there is a very strong connection between the cardiovascular function and exercise in ED and circulatory function or erectile dysfunction. Meaning that for individuals that experience erectile dysfunction, oftentimes getting an erection is a vascular and blood supply response, but maintaining is more of an exercise, more of a muscle. And so there's a relationship between what's going on with these autonomic systems and kind of our sexual function. There's also an increase in tactile sensitivity throughout the body, but specifically in the erogenous zones. So kind of around the breast, around the anus. If these tissues were already sensitive or irritated prior to getting an arousal or having a blood flow, it can also be heightened and irritated as we think about beginning sexual relations. Physical arousal and psychological arousal are not the same, and we really need to differentiate between what's happening in the body's tissues versus what's happening in that mental health and happening in kind of that the brain and what the body is thinking about. There is a stronger connection between healthy men and the correlation between genital engorgement and arousal, but women's demonstrate a high variability in this correlation. And there's not always a connection between what's happening in the vaginal tissues and the psychological arousal. So I really wanted to differentiate that the two can be very different depending on the gender. I also want to appreciate that your body is not broken if any of these things do not happen in a traditional manner. And so we want to make sure that patients feel comfortable bringing these things to our attention. Bringing us into a little bit more about the psychological phase or the phases of arousal when it comes to sexual response, there's typically 5 areas that we like to think about and then kind of break down on what's happening. So first we have a desire phase. That desire for sexual experience or intimacy or connection can be because of sexual interest or cognitive motivation to engage in sexual activities, but there's also a broader sense of potentially fantasies or physiological arousal that can also initiate the desire. So what I want to make sure is clear is that it can be driven by the psychological effect and or the physiological effect. So desire can look different for every person in that excitement phase. Once we move into the kind of the next area, then we start to see initiation of some of those autonomic processes, or we start to see the physiological response to some of that cognitive desire, where there's a little bit more about exciting, there's a little bit more attention brought to this area, there's relevance is kind of being thought about in the brain. We start to see urges or start to see some triggers of saying, my body is wanting to crave this. But then that can bring us into the plateau, which is more of a maintenance or motivations, or where the hypothalamus kind of starts to kick in. We understand that the hypothalamus is the control center for the body. It helps with a lot of those body temperature, thirst, hunger, sleep-wake cycles. It helps trigger a lot of our hormones, the heart rate and blood pressure, but it also can play a role in our behaviors and our emotions. And so as the body gets into this plateau phase and the hypothalamus is being triggered, we know that there can be some dysregulation in any of those areas that our patients are experiencing already. This is where oftentimes patients can feel like they are moving forward with sexual desires, or things kind of have to maintain and or stop because of the changes that the body is going through. Once we start to see if patients choose to move forward, there can be more of an orgasmic phase. I want to take a minute to pause and say not all sexual experiences need to maintain or get to an orgasmic state or that peak arousal or that peak response. Orgasm is defined as a rapid response to the pelvic floor and or ejaculatory function. So some patients can just get to that area or may not be able to achieve orgasm because of what was happening in that plateau phase, and that is okay. We want to make sure that we're addressing more of that intimacy that can come with sexual relations, and I'll talk a little bit more about that in kind of some foundations in our next phase. But then if orgasmic is achieved, then we will see kind of this resolution phase come, and resolutions can look different among the sex. So men can maybe sometimes feel a little bit more of a desire to kind of reinitiate or have kind of a response to go again, where some women's arousals may follow that same or have a variability of kind of being more of a shut off. This post-orgasmic resolution or refractory phase looks very different for individuals depending on how their body can recover. Intimacy is a form of exercise. And so when we think about what our patients are saving their energy for, we want to be aware of, are they saving mental energy for some of these psychological phases that their body may go through, and or physical energy for what their bodies may be going through too. And reframing this conversation that intimacy can even just be tolerating touch or being able to tolerate kind of a different level, and thinking of it as a spectrum. It does not always need to reach that kind of orgasmic or resolution phase. That brings me into kind of why is it important to bridge this topic about sexual health and chronic illness? Because intimacy can be a form of ADL, and it's part of the human experience. Oftentimes people find sexual relations to be rewarding and a desire of the body, but we also know that sometimes these bodies are not working in the way that they used to, and we want to recognize that, and we want to know what emotions come forward with this conversation. So what can we start to think about as providers when it comes to emotional intimacy and sexual function in chronic illness? The impact of chronic illness can be really disruptive to partners' relationships. It can be really challenging also for partners to meet partners. We want to understand that if you were not in an established relationship or have the ability to meet people, meeting people can look very different now. And so that can be meeting online, it can be friends for intimacy, it can be partners. And so when we think about that impact of communication, we want to make sure that we're giving patients the ability to have that emotional connection with however they're seeking a partnership. The other area that we want to think about is emotional distress and sexual function. If anxiety or depression is present, it can significantly reduce one's sexual desire by reducing the ability of self-esteem and that emotional connection. If you're experiencing those symptoms such as fatigue, chronic pain, brain fog, all of which can dampen sexual desire, it can be stressful on your partners, and it can be stressful in relationships. I also want to make sure that we talk about that not every intimacy can also be partner-based. It can also feel like it can be individual-based, and I'll talk a little bit more about that and adapting those roles in the future. But thinking about intimacy being variable for our patients, and it can be a spectrum. And we always want to make sure that we're bringing that partner stress or that caregiver fatigue into the communication and make sure patients have the words to be able to say, what does intimacy look like for you too? What does intimacy mean? What are your expectations? And giving that partner the ability to express what they're looking for, I think is also very helpful as providers if we have the opportunity to talk to patients. This is also something that I highly recommend individuals working with a mental health counselor or a sexual health counselor on as well, just so that we can recognize maybe some of the additional stress that could be present. But we also want to make sure that we're restoring that emotional well-being, and we're restoring the ability for patients to rekindle intimacy despite their illness and despite what's going on. So giving the couple the ability to alter or to recognize the fluctuating capacities. I joke that things are always on a roller coaster. You may feel good, you may feel bad. We want to validate those experiences. We also want to give them the ability to have mutual shared problem solving, mutual reassurance, and reframing the sexual experience could be as simple as touch. And what does that spectrum look like for individual couples and or for the individual personally? Validating not only the patient's emotional feelings, but also the caregiver, I think is very important. And if it feels beyond your scope, please feel like you can refer. These relationships can adapt and roles can look very different in chronic illness. Oftentimes, sometimes providers feel, or caregivers can feel like they're the provider, or they feel like they're kind of managing the patient. And we never want them to feel those altered expectations. We want them to feel like they're a partner in this. We want to feel like you're working together. And so we never want these emotions or these feelings to feel like it's eroding the autonomy of the partnership. We never want one partner to feel like they're the caregiver or have overwhelming responsibilities. And we never want the other partners to ever feel like there's guilt or shame at loss of some of these independence. We also want to recognize that body image and kind of how people feel and view themselves can be altered. And we want to make sure we provide kind of this dialectic or kind of this functioning together as a connected system, communication and relationship. And so helping couples recognize what this may look like, I think is really important too. When we also have those conversations, I often like to have partners use the word as, what does support look like for you today? What can I do to support, and normalizing kind of this ongoing negotiation or this emotional safety? Validating, how is today? Is today a good day? Is today a bad day? What are your priorities? And providing those emotional safety and that communication, I think, is really helpful. Also setting up some pacing framework. Today is green, today is yellow, today is red, I think sometimes helps manage our energy level. We need to make sure that we have, again, that a physical energy and emotional energy for what comes around, and making sure caregivers kind of understand how do they connect with these individuals. Sexual relations can be one-sided, and it can be individualized, and it can be more through self-pleasure, and making sure patients are using that kind of same framework with themselves, saying, today is a green day, maybe self-pleasure can be an opportunity, or today is a yellow day, I really need to focus on conserving my energy, and having patients know that they need to use those same pacing strategies in their sexual relations. Moving to kind of the next area that I wanted to bring up is what happens to the skin and mucosal changes in chronic illness. So we talked a little bit about the physiological response to intimacy, but I also want to make sure that we talk about the physiological response that's helping in these kind of dermatological tissues. So we know the skin can be very sensitive for some individuals with MCAS or chronic fatigue or some of these other long COVID and post-viral syndromes. The skin can lose some of the vascularity to it. It can have nervous system. It can have extra metabolic waste. So when we think about some of the chronic conditions like diabetes or immune imbalances or hormone imbalances or pain syndromes, there can also be a level of dryness or slow healing or heightened sensitivity to these. For patients who experience a lot of pain, pain can be everywhere, and it doesn't have to just be isolated to some of our musculoskeletal joints or some of the joints that we maybe hear about. Pelvic pain can also be something that can be really uncomfortable for patients. Testicular pain is another one that I will often see. And so as we start to say, where is the pain? What is that pain experience? What is your pain cycles like? It helps me understand what is happening in these issues. I also like to make sure that we're engaging kind of as if you are a primary care provider or if you are a clinician, be proactive at understanding some of these, educating patients about their skincare and protective elements. So when we routinely think about symptoms like itching or burning or tearing or dryness, make sure we're asking those clarifying questions of where are you experiencing? If we're experiencing it in the hands or the mouth or any of our mucosal tissues, we may also be experiencing it in the genital tissues as well. Maintaining that important pH, I think, is really helpful for biome stability. So as patients go through flares, and we already talked to them about how do we prevent flares for GI discomfort and preventing flares, making sure that they're tuning into what do those flares maybe look like in our genital areas, I think is also really powerful and gives more of a well-rounded discussion when we talk about what are you experiencing, where are you experiencing discomfort, hemorrhoidal tissues, irritations, bleeding, fissuring, tearing, and opening those conversations. I will also have a very in-depth conversation with patients about dermatitis or irritants and what products might be helpful. So when we talk about products, I'm going to rewind and give an education. I'm going to skip to the fourth bullet here. There's a difference between lubricants and moisturizers. Lubricants in the setting of sexual is designed for friction reduction, while moisturizers hydrate the tissue and help protect the tissues and give them a little bit more hydration. So there are times that we may use an anti-chafing stick if tissues are rubbing together, but there are daily habits that we can do of using lotion. And so I want patients to make sure that when we're describing what's going on with these products that they're using, are they using the right product with the right intent? Chronic illness can break down those skin barriers, and so we may need to give support. There's, as we discussed a little bit in our meeting a month ago about hormonal-based options, that's also important. But what is the base that the hormone is being mixed in? So whether we're providing a testosterone or an estrogen cream or ointment or patch or injection, what is that carrier with? And that can also be important to discuss with our patients. We never want to use things that have fragrance or alcohol or preservatives in it. So I often encourage the use of water-based products. So squid, H2O, good clean love, slippery stuff. These are just oftentimes water-based lubricants. Uberlube is also more of a silicone lubricant, which can sometimes, well, it does last longer when it comes to relations, but some people do not do well with anything that has a silicone in it. So what are the base products that these products are being mixed with? I think it's really important for us to educate our patients about. Also, we should be including vulvar and skincare conditions. And if there's something that doesn't seem to be going well, make sure we feel like we can refer on to some of those rheumatological or immune dermatologists, I think is really helpful. The genital area can experience lichen planus, lichen sclerosis, and other kind of tissues. And so if there's something that the patients are describing and you feel comfortable, please evaluate. If you don't feel comfortable, please refer on to somebody who does. And this is where I think having a relationship with our primary care can be really helpful too. So what can we do as clinicians? Where can we think about bringing that holistic screening of intimacy into our clinical practices? Knowing the mechanisms for intimacy through emotional connections as well as the physical logical connections and what's happening in the skin can now help us piece together what we're already hearing in clinic. So the impact of chronic illness on intimacy. We have heard all of these complaints before: fatigue, pain, orthostatic intolerance, cognitive barriers, autonomic dysfunction, hormone imbalances, but then also the stress on intimacy and recovery. So as we think about the things that we're already hearing, there is a high correlation in all of these elements that impact sexual health. So sexual dysfunction in ME and CSF, or chronic fatigue syndrome, appears to be correlated with the disease severity and the symptom burden. So what was reported is those that experience SARS-CoV-2 infection had a 2.3-fold increase in association of sexual dysfunctions for up to 12 weeks after their onset of symptoms. Additionally, 83% of individuals reported some change in their sexual life as a consequence of giving COVID, and up to 38% reported that it continued up to 12 weeks after their onset of symptoms. So when patients are thinking about their family planning or pregnancy or intercourse, these can be really impactful. A lot of our patients are experiencing this. It just may not be something that we've heard. If we don't ask, we may not know. So we know too that fibromyalgia can increase pain and cause increased sensitivity to touch. When we think about the autoimmune conditions such as Sjogren's, it's affecting the lubricants of not only the mouth, the eye, and the GI system, but it is also impacting the pelvic girdle and the pelvic vaginal and rectal tissues. Compression garments may not always feel like they're intimate or kind of sexy in a way that brings on the desire to continue to wear those compression garments to participate in relations. And so masturbation can also be fatiguing. And anytime patients experience any of these sexual relations or sexual experiences, we may also need to think about, are they factoring in recovery time? And what does recovery look like? We know that if they go to a doctor's appointment, they may crash. Why aren't we thinking about, and they need to factor in recovery after a doctor's appointment? We also need to be factoring in recovery after intimacy, and having these open conversations with our patients, I think, is really helpful. Rapid blood flow to the pelvic area can also cause penile and clitoral pain. And so when they're describing these settings of kind of discomfort in this area, I want to make sure that we're bringing that awareness to, are they experiencing pain in those tissues? And pain will not lead to sexual experiences. But when we have that change in the vascular system of bringing blood flow down to the pelvis, where is that blood flow not? It's not in the head. It's not in the extremities. It's not in those other areas. And so some patients may even experience post-coitus headaches and kind of tension and discomfort from the rapid changes in their vascular supply. And so wanting to ask when and how you experience your headaches is something I always want to clarify with patients too. So how do we bring kind of this screening of pelvic PT into our primary care or into our practices, or even just into everyday kind of discussions? I think it's always important that all of us take responsibility to screen for mood and anxiety. I think it's also important that all of us screen for caregiver strain and caregiver discomfort. I think all of us can talk about orthostatic intolerance and ergonomics. And so how does this relate? I think giving the patient's ability to be dynamic in their sexual experience, or give them kind of a very nice handout of potentially saying, well, these are positions that may not necessarily put a lot of pressure on the pelvis, or may not put a lot of pressure on the head or the neck, I think is also important to talk to them about the ergonomics of relationships and which position does not necessarily cause discomfort of the pelvic girdle or cause discomfort of the head or neck. And so I think we need to be open about the ergonomics of positioning. I think all of us can also validate the arousal and the distress that may come from this that may not necessarily correlate to what your body is physically able and capable of doing. So as we talk about some of these positional changes, or we talk about all of these elements, do what is comfortable for you. Recognize where your areas of opportunity or improvement in your clinical practice, but then also knowing where your scope or where you feel comfortable might end. It's never great to bring your emotions or your feelings of uncomfortableness into our patient relationships. But we also want to say that is not something I know a lot about, but I do know somebody who does. Pelvic health PTs feel very comfortable discussing these things. Our sexual health counselors and some mental health counselors do. But then also knowing who are your resources to refer to, I think is also very important to discuss. Where do we bring those also in integrating these into our clinical practices? We look at these areas. I love this image. I love this image from Bateman Horne, where physical, cognitive, emotional, orthostatic, sensory, and environment, all of these things are playing into their long COVID symptoms or their post-viral or their ME. And so we want to make sure that we're bringing the discussion of intimacy into the same area. And where are we saying, what does your life look like? What does your desires look like? How can I support you in this care journey as we continue to manage symptoms? We want to encourage patients to not go through that push and crash cycle. And so as patients experience symptomatic responses to certain exercise or exertion or kind of exercise that their body is going through or intimacy, is that looking like some of these pelvic conditions, or is it being triggered by intimacy? Is it being triggered by different areas? And saying, is this a system driver, or is this more of a reaction? And what is your body experiencing due to what's happening? But then validate to the patient, it's okay, your body is going through a recovery, it's going to take a process, and where do we meet them where they're at and encourage them to maybe find alternative ways of staying connected that doesn't put them through this push crash cycle. So does intimacy can also look as simple as hand holding? Does intimacy look like snuggling on the couch? Does intimacy look like a scheduled conversation or an asynchronous conversation with your partner via text messages or through writing? What does that look like? Can look so different. And we want to encourage patients to not feel like they have to push because of an expectation of a partner as well. As I like to think about, where do I help meet that focus of also addressing some of the psychological concerns, because I do feel comfortable talking about the physiological and some psychological. I also think it's important to say pelvic PT can control some of the physical responses. We can work on down training, we can work on relaxation, we can work on kind of finding the safe touch. We can work on some graded exposure through the Sensate Focus program, which is a 7-step program designed to help partners kind of work towards boundaries and safe intimacy. But then also referring to my ASEX therapist or my certified sexual health therapist, I think is also very helpful, and knowing where to go with that. I also like to integrate kind of conversations with patients about kind of forecasting their energy, forecasting their intimacy plan, forecasting their hormonal experiences. When are you going through your period? When are you not going through your period? And helping prevent miscommunications, but then also managing expectations. Not all the time can everything be scheduled, but we want to make sure that as they think about their energy conservation, that they're putting this as one of their elements that they're evaluating. I love using this idea of red light, green light, yellow, and kind of using the light system, because what that helps encourage patients to be like, I'm feeling good today, and helping normalizing some of the volatility or the roller coaster that their bodies may go through. I think is really helpful to say, hey, I think things are looking good today, or things are maybe not so much, or hey, I think this is my limit for today. And in giving patients those words to have those conversations, I think is great. And then also making sure that they feel comfortable planning in their recovery time and kind of tracking their symptoms relative to their experience. Do they have a crash after? Do they experience fatigue? What is their body going through as we go into their sexual experience, but also coming out of the sexual experience? These home-based practices can look very different, and we may need to adapt them to our patients, but I think if we at least give them some words and opportunity to bring the conversation forward, it helps us as well when we say, what's the primary focus? We can't fix everything today. Let's focus on one thing. And intimacy may be something that's important for patients. There are individuals who choose to be asexual or choose to abstain, and that is okay. And we want to make sure that patients feel, if this is something that you want to discuss, I am a safe partner and ally to open those conversations. As we encourage our empowering our patients to talk about these and ask questions. We can provide resources. We can provide some of the books that's referenced. We can provide the referrals to the clinicians, but recognize that not every partner really knows about their condition or knows about long COVID or knows about chronic fatigue. And so as the patient is learning their own symptoms, we want to encourage those around them in their social circles to feel comfortable about learning about the experience as well. And so as partners are trying to communicate what they're going through, we may need to recognize that we need to give them words and give them opportunities to continue to inform their circle, and that can be helpful. So where do you find resources near you, or where do we find additional support? I do always love referring to the Cozen screening tool because it does help us recognize if a patient should or could benefit from a pelvic PT referral. And the symptom question at the very second to the end is, does sexual activity increase one or more of my other symptoms? This is something that we can ask patients that says, does discomfort with sexual activity experience happen? And then I know somebody who could help have those conversations with you if and when you're ready, especially as we start to prioritize what area we're going to focus on in their recovery. Where do you find pelvic PTs? These are two wonderful resources to be able to look up. There are kind of different levels of training when it comes to recognizing pelvic floor PT. We have kind of an introductory level, then we have a little bit more of an intermediate level, and then we have an advanced level. And a lot of times sexual health is discussed in some of those advanced levels. I also love to refer to AASECT for sexual health counselors and finding partners that are willing to open these discussions. I think as clinicians, we have also the opportunity to continue to educate about what we're treating and what our scope is and what their scope is. And as we work towards some of these kind of couple therapy, I think these are great allies to have. And there's multiple here at least in Salt Lake Valley, but we can also find them throughout the country. I have provided my references as well, and I'm happy to share these with Clay in the group later. But thank you for letting me have the opportunity to come and share and to open this discussion about intimacy and sexual health, but then also what we can do as clinicians to empower our patients. So, perfect. Any questions for me?
Thank you so much, Katie. I just was impressed at how this is so underrepresented or evaluated in the clinic. I would assume, like, I don't ask patients much about this, and so it's probably under-recognized in terms of how much it impacts people, but it also highlights how many aspects of life, long COVID and infection-associated chronic illnesses can affect people, even in ways that we may not be recognizing in the clinic setting. So I'm so glad we've covered this because it doesn't usually come to mind. I'm sure for you as a pelvic floor therapist, it's something that comes up more often, but patients may feel uncomfortable to bring this up with their healthcare provider. And you kind of mentioned if you don't feel comfortable discussing this, then maybe don't. Right? Like if you feel comfortable having a conversation about this, then how can you help the patient feel more comfortable bringing this up?
I think this is where we want to make sure that we focus on the alignment and the goals of the individual patients. And so when we ask our patients, what's important to you, or what's your primary focus, or what are your goals, as they start to list off the things that are kind of uncomfortable or challenging to them, we do want to say if they give us any illusion of connecting with my partner or being intimate with my partner or family planning or managing this so that I can achieve that, I think sometimes we need to hear that there is a connection between some of the questions that we're asking and the answers the patients are providing. And then you can say, I want to be respectful that your body may be going through a lot of changes right now as you're having some of these illnesses and these these diseases that your body's going through. I also want to focus on what's important to you. And if intimacy is important to you, that may not be something that I understand or I can control, but I know people who can, if that is your primary focus for now. And I think that when we give the patient the opportunity to tell us what do they want to focus on, if we extract those elements that may sound like it's connections, or the ability to connect to the human experience, then we also want to say, does that look like intimacy? Does that look like part self-pleasure? Does that look like different things? And just feel comfortable asking some of those questions that may be something that we've never really thought about as clinicians.
Thank you. That's so helpful. So I also want to highlight Dr. Bateman, Dr. Brown, and Dr. Hoppers as our mentor panel. And if they have any questions or anything about this topic, or anyone else in the chat.
I would start by saying I don't think I have any specific questions. That was really thorough. But leaning back on my years in internal medicine, right? I really appreciate how under valued this is. You know, I mean, we're none of us are really. I mean, there are varying levels of comfort in doing this, but it's really about understanding your patient, right? And being able to see, like you said, bringing it up in a way to find out what's important to them. And once they feel safe in your care, then you can kind of start that conversation and have as much conversation as is needed for the situation. I have been, throughout my time in Salt Lake here, there's been some really good therapists that I could send people to who are specifically trained as sex therapists to be able to explore some of this. But there's also the medical side, right, as well as the relationship side. So really helpful. And thank you very much for being so articulate and being able to and model for us, right, how we can do this.
Yeah, I just want to echo what Dr. Bateman said as well. I feel like in our training traditionally as physicians, for example, or there's very little, I feel like, discussed about that. And so I think to some degree, it's a little bit, the hesitation can be, I could bring it up, but I don't know the resources. So I think presentations like this are huge to know what resources are available. But also, I think fundamentally coming back down to what you're saying is how do you come back to what's important to the patient? Because that getting at the heart of that is really key. Yeah, I think it's a good opportunity for us, and even also sometimes to think sort of non-traditionally for, could occupational therapy help with something? Could, physical therapy or other things, in addition to traditional therapies as well. So excellent presentation. Thank you.
I also wanted to point out, I was thinking about this, how there sometimes patients will report to me that they have a boyfriend or a spouse that doesn't understand ME/CFS or long COVID, and it's causing friction because the spouse or partner is saying, you need to exercise, you need to get in shape. And this can be kind of a hold it against the person, when in reality there's so much going on, fatigue and pain and pelvic congestion perhaps, and how much that can affect relationships. And I hear it a lot from patients saying that their partner doesn't support them in their not working or not doing as much activity, but I hadn't considered this aspect, that this is probably a big role as well that would impact relationships. And so how can we better educate family or sexual partners about ME/CFS, and what your thoughts are about that?
When I phrase this conversation with caregivers, I do explain that yes, sexual relations is an activity of daily living or an ADL or things that we want to desire. Now, it doesn't necessarily have to be a daily activity, but it is part of the human experience. When the body isn't working the way that we expect or is not able to respond to physical activity, it may not also respond to the physical activity of intimacy. And I always explain that sexual relations is an exercise. Getting an erection can often be a vascular component. And so if patients are struggling to get a vascular component, I'm validating their concerns. I'm validating that there is a vascular element that might be present as we've continued to talk about their orthostatic intolerance or any other headache management or other symptoms that they may be experiencing. But I also want to validate that these are muscles that are meant to design to contract and relax. And if we can't control them the same way that we control our arms or our legs or our body or any other element of ourselves, we can't expect them to respond appropriately as well. When we bring in that relationship to partner, I explain to partners that there is a lot of there. I kind of explain the cycle and I explain what the body is going through. But if they recover, they need hours to recover after taking a shower. There's likely going to be a similar component to needing to recover after intimacy. And so then I bring into that, what could intimacy look like for you? What does connection look like to you? Is it physical touch? Is it being around each other? How do we continue to maybe think about this as a spectrum, not necessarily what relationships were with orgasmic experience or maybe frequency that it once was, but knowing that there is still the ability to connect through this care journey, to be able to express appreciation, to express the language of love that maybe is receptive to the partner, and opening those conversations to say, I understand that this is something that's important to you. How could that look different now that my body is going through this experience? And then opening some of those kind of partner conversations about negotiation, I think is really helpful too.
Yeah, Dr. Hoppers.
Can I ask a quick question? Katie, have you had patients with tethered cord or CCI express difficulties with sexual intercourse over and beyond the fatigue limitations?
Yeah, just because of the neural tension that can happen on these tissues, I think it's really important to recognize that nerves don't stretch, right? They glide and slide. And so depending on the ergonomics or the position that the body is in during intimacy may pull or put more tension on some of those tissues. And so deep squat relaxes pelvic floor, but deep squat also causes a lot of neural tension on the sacral tissues. And so that may not be a position that is comfortable for patients in that. They may not feel comfortable laying on their back and may need to lay on their side. They may not feel comfortable supporting their own head if their body is in a closed upper extremity closed chain position. So they may need to think about what positions are comfortable so that they don't experience neural tension, headaches, or discomfort. But then also, where is this not going to put additional stress on any other orthopedic joint or on these vascular and or neural tissues that may be feeling compressed? If the head can't tolerate head extension, you do not want to be in a sexual position for extended periods of time with head extension. And so I want to make sure that patients understand that their ability to tolerate the gravity world also will impact their ability to participate in relations, because it is a time upright or a time laying that may be uncomfortable for them. And so then giving them the ability to be dynamic and change, I think, is really important for patients to understand. It does not always have to be intercourse. It can also be outer course, and that can look different. And so validating your position or your symptoms that you're experiencing may make this look different than what you had experienced and or what traditional images may show us.
Thank you.
One of the questions in the chat is you mentioned lubricants versus moisturizers, and just, do you have a recommendation regarding internal moisturizers versus, you had mentioned, external moisturizers? Yeah,
so internal moisturizers or moisturizers for vaginal tissues can be compounded through estrogen and hormonal base. So women who start to experience perimenopause may benefit from a compounded tissue or compounded, and then it absorbs through the tissues. It can be through suppositories, creams, or ointments, depending on the base that the estrogen is mixed into, can also be impactful. There are also moisturizers through some of the companies that I showed, Good Clean Love and Slippery Stuff, that is an internal moisturizer to the vaginal tissues and to the mucosal tissues. So just like we can recommend Biotin for the mouth or a mouthwash that may lubricate the mouth if somebody is experiencing a dry mouth, or saline drops in the eyes, there are moisturizers that are designed to help the internal vaginal tissues and or internal rectal tissues through suppositories or creams. For our male partners who have external tissues, there are also things that can hydrate the penile shaft and those tissues as well that we want to be cognizant of. And so they can be applied to the glands and other areas that can help hydrate so that there's not dry skin or flaking that can also happen in the area. If the tissues are still very dry, there are some other compounds that are also steroidal based that can be recommended by some of the rheumatological or dermatological providers that can also act as a prescription or something that can help these tissues as well. I also encourage patients to start with the most basic answer: hydrate. If all of your mucosal tissues are dry and you have symptoms of orthostatic intolerance and symptoms of POTS, let's just get some water in you. Let's just get some general water in you too. And that can be really impactful for patients as well.
Excellent. Thank you. I have, Dr. Bateman, go ahead.
Well, I was just going to ask you another question, Katie. Is what other providers do you like to partner with? I mean, there's so many dimensions of this, right? And not every specialty has of medicine has people who deal with this. But you work with gynecologists or other, talk therapists, or who do you value as your teammates in this situation?
Yeah, that's a wonderful question. Our network continues to grow. And so for my male partners, I often like to work with urologists who specialize in men's health and men's sexuality, and they can help us evaluate the hormonal-based treatments, and they're my kind of go-to for sexual medicine in the men's world. I also like to partner specifically with gynecologists or urogynecologists. So I love our OB gynecologist if the patient is of baby making age or would like to make or is having children, but I really enjoy working with more of my urogynecologists or my gynecologist specialist coworkers who are helping people through that menopausal transition. Within the University of Utah system, there are menopause specialist gynecologists that I will partner with to help with some of this kind of transition or sexual medicine changes that are experiencing. In addition, I like to work with our mental health counselors, either if there's more of anxiety or depression, but within a subgroup of that, working with our ASECT counselors for more of that sexual medicine partners is important as well. I also think a lot of this gets put under the primary care blanket and primary care providers who are helping manage a lot of areas and a lot of symptoms. And so having those allies through our MD coworkers is also very important. I also will work closely with our occupational therapist coworkers if there's an ergonomic component or kind of a management of kind of our other therapies that are kind of sister disciplines to physical therapy. And I think that they can be really helpful in looking at this whole picture as well.
Quick question for you. Any resources or recommendations where working with like transgender patients or LGBTQ plus patients that may not fit in the traditional silos?
Yes. Within the state of Utah, the University of Utah has a sugar health clinic that will often see a lot of these patients who recognize as non-binary or transgender, and partnering with our primary care providers that do a lot of their hormone management, I think is really helpful there. Additionally, we have patients through our transgender program who maybe choose to go through gender reaffirming surgery. So working with our urologists and or plastic surgeons, I think has also been very helpful. And that's their primary focus of their practice is reconstructive urology. And I think that they're a great resource to work with as well. I think as providers, we have the opportunity to recognize our own biases and recognize maybe what does a heterosexual relationship look like? What does a homosexual relationship look like? What does intercourse look like? Are you receiving intercourse? Do you have receptive intercourse vaginally or rectally? Do you want to participate in penetrative intercourse and having those conversations? And so when it comes to working with our patients who maybe follow a non-traditional management or maybe have choices that don't look like what we've always thought about in the textbooks, there are these providers and there are transgender program collaborations that we can outreach to. And I know of them within the university system, and our primary care providers that are at Sugar House are great to work with. I also will encourage patients to continue to get their annual screens. And so HIV screening and other elements is also something I really advocate for. And we should continue to do our annual PAPS or depending on your frequency and your prescription, annual and or 3 to 5 year annual pap smears. And so encouraging some of those sexual medicine follow-ups, I think, is also important for our patients too.
One other question I had was, or I guess comment was, how often I've seen patients who have been going to pelvic floor therapy and are not diagnosed with ME/CFS or mast cell activation or some of these conditions, but they're being treated. And so the importance of the therapists or other providers screening for ME/CFS and orthostatic intolerance and mast cell activation, because often patients are getting treatment for the symptoms, but it's not recognized that this is what's going on. And so hopefully this will help to raise more awareness among healthcare providers that these symptoms can also be just symptoms of a bigger thing affecting their whole energy metabolism and health. Have you seen that a lot of patients come to pelvic floor therapy for these symptoms, but they haven't been diagnosed or it's not been recognized that they have these conditions?
Yeah, I think that's where all of us as healthcare providers can continue to improve and recognize our kind of what are we chasing in terms of symptom management versus when are we getting to the root cause and when are we getting to the driver of what's going on, what's the pathophysiology or what's going on. We manage symptoms, we treat kind of the pathophysiology, and we need to make sure that we're looking at that whole picture. I think as pelvic floor PTs, and even just in general in medicine, we're trained as generalists, and then we kind of get specialized, and then we kind of get specialized, and then we recognize what we don't recognize or what we don't know, right? We all think we know everything, and then we realize we know nothing. And so if you ask a clinician of 40 years, they're going to say, I know nothing. But you ask those new clinicians, they say they know everything. And so as we recognize that we all continue to learn and then take that opportunity to say, hey, would your therapist or would somebody be willing to have an additional conversation about these elements? Would somebody be willing to learn a little bit more? Hey, I think this is what's going on. Maybe let's do some research as a patient or as clinicians, continue to educate our coworkers around us to continue to get better. And
Yeah,
it's
I
always a
totally
battle.
agree. And I know we're almost out of time, but I have to mention this as well because you kind of touched on this, but trauma, past or ongoing trauma, and how that can affect the autonomic nervous system, and regarding this, and where you send or who you refer to for trauma.
Yeah, so if there's still a lot of emotional trauma or kind of more of that psychological trauma, I'll definitely work with our mental health professionals to do some EMDR or some cognitive behavioral therapy. If there's physical trauma, the body may still have healed, but then there might still be recognizing that it's holding on to that tension. And we want to make sure that we help the patients kind of work through feeling safe, feeling touch, feeling the intimacy in an element that is protective and that doesn't heighten the autonomic response or the protective or the guarding response, or doesn't necessarily heighten that kind of clenching response. And so trauma is definitely a big area. We could come back and talk about trauma and trauma-informed care, and I would love that in the future, but it is one that I intentionally kind of left off because 1 in 4 of women and 1 in 5 men have experienced some sort of sexual trauma at some point in their life. And statistically, we are going to see those patients as well.
Thank you. Yeah, we could go down a bunch of rabbit holes, but so thank you so much, Katie, for touching on this, and everyone who joined today. Don't forget to claim your CME credit for attending. And our next session will be on nutrition in long COVID management. So in August, we hope to see you all there. Have a great rest of your day.